Dzień dobry. Goedemiddag. Good afternoon. I'm Brian Beyers. I'm from Cape Town. Although the hospital where I work looks a little bit more like the bottom of this photo than the picture up top that you might be more familiar with. We are in the clinic today. We're seeing a 35-year-old male. He's been diagnosed with diabetes about 6 months ago. He's on standard treatment and he's pretty well controlled in terms of his glycemia. For 15 years, he's been having bilateral foot numbness, and this followed varicose vein stripping. However, over the past 2 years, he's been having burning dysesthesia in both his hands and both his feet equally affected. And this started after being diagnosed with a very rare condition called COVID-19. The clues in this case is diabetic, he has sensory loss, and it's a glove and stocking distribution. So when I saw this case, I quickly needed to brush up on all the common causes of neuropathy in diabetics. The first being diabetic sensory polyneuropathy, DSP, and axonal neuropathy, pain and temperature sensation affected first in a glove and stocking distribution. Diabetic amyotrophy, or polyradicular neuropathy, with its abrupt onset of a painful neuropathy, mononeuropathy and its associated multiplex, and lastly, the inflammatory neuropathies like CIDP, proximal and distal involvement equally affected, areflexia common. So we checked the vitamin B12 as normal, and I made a diagnosis of the garden variety DSP. I started him on pregabalin, and I said to him to follow up in a month. So now we're together in the clinic again a month later. Not only is his sensory symptoms unchanged, now he's saying that he's struggling to tie his buttons. He's struggling to maneuver the pedals of his car. This time, I do a more thorough neurological examination, and the pertinent findings are distal symmetric proprioceptive loss with motor involvement of both his hands and lower limbs with intrinsic hand muscle weakness. You can agree with me, this does not fit a diagnosis of DSP anymore. We sent him to a neurologist, and nerve conduction studies did not reveal an axonal pattern, but a demyelinating pattern with about a 70% conduction block. An evaluation for common demyelinating causes were undertaken. Connective tissue disorders, infective conditions were ruled out. The only pertinent finding was albuminocytological dissociation on his CSF. He had the atypical antibodies done, and the anti-MAG was negative. However, the anti-GM1 antibodies were positive, and a diagnosis of distal acquired demyelinating sensory or DADS neuropathy was made. Now, some of you might know what that is. Me, and along with many others, don't. And if we find some literature in the diabetic population, you would come up empty. What is DADS neuropathy? It's an atypical variant of CIDP. It's an immune-mediated cause of demyelination. Most cases have an identifiable monoclonal antibody, and this is not an unusual situation. POEMS syndrome is another one where you have a lambda neuropathy. You get different types, and this is important for diagnostic, treatment, and prognostic implications. There's an idiopathic variant where you don't find a paraproteinemia, and then the DADS-M where you have the antibodies, DADS-M being MAG positive or MAG negative. The classic presentation, and this is probably the most important slide, is where CIDP gives you areflexia and predominantly motor, but also sensory findings. This is a distal symmetric predominant disorder. There's proprioceptive loss, which should always direct us away from a DSP. Lastly, whereas idiopathic DADS can be treated in the same way as CIDP, in the typical MAG-positive DADS, the treatment is there's a lot less options available. IVIG was instituted in this patient, and the prognosis is slowly progressive. 3 months later, we're back in the clinic, and our patient now comes in and he says that unfortunately he's still struggling with his buttons, but now he can drive his car without any difficulty. And the nerve conduction studies were repeated, and the conduction block now sits at less than 50%. What is the take-home message today? Patients present with typical problems. And part of the case definition of a rare syndrome is the fact that we don't see it every day. So we should be looking less towards the typical features of an atypical syndrome and be more cognizant of the atypical features of common conditions. So that when we see a diabetic patient presenting with neuropathy or sensory changes, we should stop and think again. Thank you.
Thank you. And now, any comments, questions?
So when you saw the patient at the first visit, the patient had neuropathy before the diagnosis of diabetes. Do you get neuropathy before the diagnosis of neuropathy that could be due to diabetes?
So this patient was diagnosed 6 months earlier with diabetes, but if we know that 50% of our diabetic population stands undiagnosed at any time, then diagnosis could have been present for much longer. But that was definitely one of the first clues, is that the temporal relationship of the diabetes diagnosis and the onset of neuropathy was too short. The second thing was his glycemic control was so good. I didn't show it, but his HbA1c was sitting at around 7.1%, which is also out of keeping, not impossible, but out of keeping to your typical complications.
Yep. So thank you for sharing this very interesting presentation. A question, maybe a broader implication of your case. What would you suggest in terms of systematic investigation for a patient with diabetes presenting with atypical presentation?
I think there's a theoretical answer, and then there's the pragmatic approach. We're staying in South Africa. I'm in the public healthcare sector. Our funds are limited. When we get a neurology date for a patient, it sometimes takes up to months. The theoretical answer is whenever there's atypical features, the two I just mentioned, I think I would be prone to investigating earlier. If it's a clear-cut case of a DSP or an amyotrophy, I think I would stand back a little bit, institute the right treatment, and see if they respond typically.
Thank you.
Well, thank you. Last comment or question, Ali, please.
Thanks. Again, fantastic presentation, very eloquent. Another clue on, I wanted to just add something to Dr. Panju's comment, is that was a retinal exam done on the patient, an ophthalmoscopic exam done formally?
It wasn't done, and to be honest, if I performed it myself, I would really not trust what I found. But he was subsequently referred for a fundoscopy.
The reason why I'm asking is, in the same line of thought, is that in the absence of retinopathy, if they get rapid kidney disease, they get other microvascular complications, it's probably not diabetes, right? It's probably something else atypical. So a good retinal exam, of course, I send them to eye care specialists also. It's really important to document that, because if it doesn't match the timeline, then you got to think outside of the box like you did here in your case. Just a couple other tests that I would have done earlier on is probably a TSH and asked about alcohol, because these are common causes of neuropathy also, thyroid dysfunction and alcoholic neuropathy.
Well, thank you. No more questions. Thank you for the presentation.